To me, the biggest thing that jumps out in my head when I'm triaging patients and like getting a story on them is when I hear that they have this ripping back pain, like in the center of their back, that always cues me into thinking more aorta. Not that it can't be anything else, but that kind of throws a trigger in my mind just to keep that as like a differential diagnosis.
The voice you're hearing is Alex Greene. Alex is a flight nurse from Lifelink 3, one of my colleagues, and we had a shift together. We had a thoracic dissection, and we were able to meet the heart rate goals, but it was really hard to meet the blood pressure goals. And so we both did a bunch of digging into, is a labetalol drip better than a nitroglycerin drip? And so he came on and we had an excellent discussion. And so Sam, listening through it, do you have any memorable aortic transports?
Just the general thought of, you have esmolol going and you have nicardipine going, and the thought that as you ramp up those infusions, if the blood pressure does have this large drop, you wonder, did the patient just rupture or did the blood pressure medication start working? That's it's always stuck out as a really scary thought to me, is that you have this potential hypotensive disaster where this person's aorta could explode. But in the meantime, like before that huge drop in blood pressure, you're trying to lower their blood pressure and you're wondering which one is going to happen first. So just kind of that general thought process. Yeah.
Yeah, I thought it was a good discussion. It definitely is more of a discussion. This is what it sounds like when we're sitting at the table talking about calls and referencing, even in the podcast, you'll see how we reference some guidelines and we're looking stuff up when it comes to those specific goals. As always, follow what your local guidelines are. Typically, you're going to get a blood pressure and a heart rate recommendation from either the sending, receiving, etc. But I know you had a graphic that you were gonna share with us. If you wanna throw that up real quick. I thought
Yeah,
that
yeah,
was,
I'll share that in a second. So just to kind of preface it real quick, you
yeah.
guys briefly touched on how you can have these different signs and symptoms. Like for example, I think you guys used like an MI plus stroke symptoms, and when those two don't seem to go together, it seems like two completely unrelated puzzle pieces, and you wonder what's going on with this patient. And it can lead back to, well, what's the blood supply for both of them? So yeah, I have this graphic I'll throw up where it shows the location of where the dissection might happen, and then across from it, it shows what the signs and symptoms might be. So I throw this up for students as a reference. So let me get this screen share up real quick. Yeah, so here's that graphic, and the locations start off, and these lines cross over all over the place. But the aortic valve, that can prolapse, you can get regurgitation and therefore heart failure from that because it can't hold the pressure in the aorta. Then going up, the coronary arteries, like you guys were talking about, the myocardial infarction. And then if it goes down to the pericardium, dissects there, you can get blood leakage, so cardiac tamponade. And then the brachiocephalic or the carotid or even the left subclavian artery is where you can get the neurological symptoms, stroke, syncope as well. Subclavian, this is where the upper extremity pulselessness or differences in pulses come into play, hypotension, pain. And then this one isn't talked about very frequently, but the intercostal arteries and then paraplegia as well. And then these are rarely pictured in diagrams of the aorta, which is the celiac and mesenteric arteries. This is where that abdominal pain partially can come from, besides the aorta itself, and the mesenteric ischemia. And then going down, obviously renals, back, flank pain, renal failure, and then this all the way down to the iliac arteries, where you get this lower extremity pain, differences in pulses or pulselessness down there, and then weakness as well. So that was the graph that I'll show students, and it kind of makes sense when you have these seemingly unrelated things. You kind of just follow the track of the aorta and you say, how can these things fit together, even though they're seemingly totally different organ systems?
Yeah, and I've had some people reach out and ask, can you see a thoracic dissection on ultrasound? And you can, right? It gets harder to see when you start getting into the descending territory, right? Where it starts to become the abdominal aorta, just because of the gas and stuff. I know with some ultrasound probes that are really high powered, you can see it, or you can see maybe just the part that's like subxiphoid by
Mhm.
where the IVC is. But typically, if you're doing like a peristernal long view, you'll notice a widened aortic root. Sometimes you'll see the dissection there. And then when you have a peristernal long view, you know how there's like that little dark circle in the bottom right corner?
Yeah.
You see like a short axis of the descending aorta. if there's a dissection, sometimes if it's, involving that area, you'll actually see a little flap there as well. But it is harder to tell once you start getting closer to the abdomen.
So there's a peristernal long. Do you find a short axis to be helpful at all?
I typically don't. I know you can see, like, at the different levels as you go up, you can see the aortic valve. I think if you're questioning it, maybe switching over to, instead of it pointing towards the right shoulder, point it over towards the left, the probe marker. And then sometimes you can see the dissection in there, but typically if it's going to be obvious, you'll see it on the peristernal long axis.
Nice. Well, yeah, this is a really good discussion on not only the nuances and the troubles that can come from trying to titrate blood pressure, but also the assessment of that blood pressure and how you do it, and then mixing in ultrasound to figure out how these body systems are connected as well. So should we get to the episode?
Yep, let's roll it. Yeah, and you're not used to feeling pain from your aorta. That can be really interesting to see how that manifests. I was reading something like, I want to say it was like 30% of your thoracic dissections won't even feel pain, or they won't have a chest pain or back pain. But traditionally, I agree. Like when somebody says, I have tearing back pain, that's one of those things out of the textbook that almost makes you think the patient read the textbook, because it's explained like that so often. The other things that make me perk up that this could be a thoracic dissection is, for one, if they have, let's say you have like an inferior wall MI, right? Like you have elevation in 2-3 and AVF, and then they're complaining also of some blurry vision because you can dissect into the actual coronary artery or up the carotid into the brain. And so when you have those things that don't make sense, okay, they have chest pain, they're diaphoretic, tearing sensation, and they have stroke symptoms or blurry vision. I always throw the ultrasound probe on every patient that has chest pain or ST elevation, because I just want to rule that out, that it's not dissecting.
Yeah, it's a good thing to rule out before you start throwing the thrombolytics in there and everything.
Yeah, and then there's the ones like the, what is it, Marfan syndrome, or the connective tissue disorders, or Ehlers-Danlos. I don't know if I'm saying that right.
Yeah, they can touch the back of their hand.
Yeah, that could be Marfan, because they're typically large, tall people. And so I shouldn't say large, but tall in general. Yeah. And so they're like, oh yeah, you can do that. That means they could have Marfan. So not that you should be bending all your patient's fingers backwards, because it could be that they smoked and have hypertension and the other predisposing risk factors as well. So there's the one that you come across in the field, and then there's the one you're going in and they have already diagnosed it. We walk in, and obviously every single one of these I've seen has been in excruciating pain, diaphoretic. They look very sick. And my first thought is not beta blockers or calcium channel blockers. It's like getting their pain under control, because I've seen it where they're like throwing on nicardipine and they're throwing on labetalol slugs and they got esmolol up, but nobody's addressing the pain. So the first thing is like taking care of the pain. And I think you can be pretty generous with the analgesia on this one. What are your thoughts on pain management?
I think it's definitely right at the forefront with those medications that you just listed, the esmolol, the nicardipine, labetalol. Like those are all really great drugs for this situation. But if you're still in pain, you're still going to have that elevated blood pressure, that elevated heart rate, which is not good in this situation. So yeah, I believe being more on the aggressive side versus the cautious side would be the way to do this. Fentanyl is a great drug. We carry it in our shop, and you can be pretty generous with it without affecting their vital signs too much. If you have a patient that's super hypertensive, like I'm talking 180s over 120s, elevated heart rate, you could think about some pain medications that can maybe help your vital signs a little bit, like maybe some morphine, or even I've seen facilities give Dilaudid, and Dilaudid's like the godsend for pain.
Yeah, and anytime you're given these higher doses, I think it's become all of our practice at our shop to put them on a smart cannula and watch their CO2, watch their ventilation rates, because you're not really worried about the blood pressure tanking on these, but you could still get the respiratory depression.
Yeah, absolutely.
Throwing on a smart cannula to where you can monitor that, I think that makes a lot of sense. So we give them some pain management. Now, when it comes to heart rate or blood pressure, second, there's a lot of recommendations to start off with the heart rate. to do what a lot of sources call anti-impulse therapy. So what's the idea with the anti-impulse therapy?
So what I understand from it, or what I get from it, is the goal is to make your vitals in the ideal spot where you're not going to have that excessive force and excessive amount of pumps on that aortic aneurysm to make it bigger and bigger. So you want to keep that as ideal as possible while also still maintaining perfusion to all your organs, your brain, your heart, everything. So to have the anti-impulse, if you were to lower your blood pressure first, your heart rate's going to sense that, your cardiac output, and they're going to be like, I need more flow. So they're going to increase their heart rate, right? So to get ahead of that, using the beta blockers, you're going to effectively lower the heart rate so that when you, within reason, like a safe parameter, so that you're not going to have that reflex tachycardia, which would then in turn turn your pressure up and could definitely make things go pretty chaotic pretty fast. That's what I take from it. Preventing that safety mechanism that your body naturally has to preserve life. You want to almost tell it, like, I don't want you to overpump your heart right now, because if you do, you're going to kill yourself.
Yeah, I think of the anti-impulse therapy as like, you ever see where kids are like not touching you, or they're just like touching one spot over and over again. It's irritating after a while, right? Because it's that sheer force is really what it is. And it's hitting and hitting. It's like somebody trying to kick down a door. It's typically not the first hit, but if you keep doing it, that is those impulses that's making that dissection rip a little bit more and a little bit more and a little bit more, and it's making it grow. So the first idea is you need to prevent how many times you're kicking the door, right?
Yeah.
And then you lower the intensity of those kicks as well. And so if you give, like you said, you give something like a calcium channel blocker and you drop the blood pressure, you're going to get a reflex of tachycardia.
Now you have more kicks kicking down the door.
Yep, exactly. So we start off with esmolol. Typically, it's 0.5 milligrams per kilo as a loading dose, and then you start a maintenance dose. And you can go all the ways up to 200 mics. It's 200 mics per kilo per minute, I believe, right?
Yeah, I think that I have it pulled up right here just to make sure that we reference it right. But yeah, it says 50 to 200 mics per kg per minute. And when you titrate, if you need to go up, you bolus some half the milligram per kilogram. So if it ain't working, you give them a little extra and you turn it up.
Yeah, and that's an important thing too. As you go up, you also need to rebolus each time you go up as well. This is one of those drugs that I always am like, I haven't done this in a while. I got to look it up, because there's two dosing strategies. You got the load, and then you got the maintenance, and then you have to rebolus it. So even
one's
just
milligrams,
now,
one's in micrograms, and you're like, which one is it?
Yeah. So the esmolol, it seems to be the most common one, and it does a great job of keeping that heart rate right where you want it. Typically, less than 60 beats per minute is what I see. That's what most recommendations say, is to get that under 60 beats per minute.
I've never really had an issue lowering the heart rate in these patients, especially with esmolol. I feel like it works wonders for that beta blocker effect. That's just my opinion on it, but
yeah, it's not the heart rate that it becomes the issue, right? It's the
that's why we're talking. What's the blood pressure?
And then the other thing is, the thing that makes esmolol nice is if all of a sudden you do need the compensatory tachycardia, you can peel off the esmolol, and it's got a very short half-life. Knowing that, it's also important that you don't go, we got to get in and out of this place really quick, and you pause your esmolol, because then you're starting from scratch again. It's got a very short half-life.
Yeah. If you got those drips already infusing, it's like you don't want to really stop those therapies. Take that extra 2 minutes, get those on those pumps, and go. It's not like pausing heparin for a STEMI or something where you're like, we can restart that later. But sorry.
Yeah, these are actively controlling vaso effects, the hemodynamics. So we got to keep those going. Now, if they got something like a fentanyl drip going, I probably will just give them boluses of that, maybe continue it in flight. But anything like your esmolol, your nicardipine, I think it's important to keep that going. Don't have any interruption in that. Otherwise, your blood pressure skyrockets again, and you're playing catch up.
Yep.
Okay, so max dose of esmolol, typically you see 200 mics per kilo per minute. However, like you were mentioning, that's not typically the issue. The issue is these sky high blood pressures. And I was talking to Sam Ireland about this yesterday a little bit. And he was like, do you think sometimes if it descends down into the renal branches that you could get this like renin response where it's just like going crazy, releasing it, thinking that it's not getting perfusion to the kidneys, I'm like, that could be the issue, right? Because in a perfect world, you would start nicardipine, you would titrate up with a max of 15. In a perfect world, you wouldn't even have to get to that, and the blood pressure would come down, and you'd have your nicardipine and your esmolol, and you've been taking care of
Yep.
pain with fentanyl. However, once you get to 15 and you're like, we are still at 180 over 130, then it's, where do I go from here?
Yep.
What is it? There ever a situation where you go above 15 with nicardipine? When you're working under a guideline, that's the max. That's what the manufacturer
Right.
says the max is. So that was the situation we were faced with, is like, all right, we're still not taking care of.
When they do dissect, they actually want their systolic between 100 to 120 and their heart rate less than 6 or around 60 or less. But yeah, I agree. Like you want to have those strict parameters where you don't want to, you draw a line in the sand. If they go over it, you act. Yeah. When that happens, I'm kind of starting to think, well, what else can we do? It's not ideal to go up crazy high on nicardipine, and it's how high can you really go on your beta blocker until you effectively almost kill them. I've been really hearing a lot of push from, I guess not hearing push, but from what I've seen on flights, or they're starting nitroprusside, and the vascular surgeons are really liking that. I can see why, being that it's that nitrate, it has fast on, fast off. You can usually titrate to effect pretty quickly, and it's not very, when you already use the beta blockers, you're defeating that impulse to overcome that vasodilation happening. So the nitrate would actually do, I feel like, fairly well. So I've been curious more on how that would look in a picture. But the thing is, I feel like nicardipine sometimes takes a while to work, and given our short flight time environment, we don't really ever get to see it probably hit full peak effect, because typically we're doing runs in the metro. So it's like 45 minutes to an hour. And usually by the time you've maxed up your beta blockers, you're now starting nicardipine. You have about 15, 30 minutes left of your flight, and you've maxed it out and you're on final. So you're like, shoot, what do I do now? So my worry is that nicardipine will finally start to take effect. And if you've started adding nitro, now your pressure is just going to plummet. So I feel like
Yeah.
it's very time sensitive, I feel like, on when you want to start it, and like when your nicardipine has been started as well.
Yeah, and it's hard because you want to get that blood pressure down pretty quick, right? You don't want to be like, it'll take 20 minutes for this to kick in. Not having nitroprusside, and I know the cases that you and I had, that's something that once we got there, they were like, oh, do you guys carry nitroprusside? We don't, right? We have nitroglycerin, which is still a decent option, and it's listed in this article that I'll put in the show notes as well. But it got me thinking, maybe in the future, I might ask for that. I might ask for some
Yeah.
nitroprusside.
Yeah, we do have a
to
guideline
bring
for it,
with
so
me,
we
so
can
that
use
way.
it if we can get access to it.
Yeah, I don't
Um,
have a whole lot of experience with it.
I personally don't either. Have plenty of experience with nitroglycerin. That's bread and butter.
Yeah.
The nitroprusside is where I can't imagine it's entirely different, but yeah, I've heard someone say, though, I think Kevin Ritzman, and we got into a aortic dissection discussion one day, and he was talking about how, maybe you can caveat off this, he wouldn't take a nitroprusside drip unless that patient had an arterial line. And I can understand why, because you want to have something that's constantly monitoring. I don't know if nitroprusside has that antihypertensive effect like Cleviprex, where like you can drop that blood pressure in 90 seconds. But I don't know. What's your take on that with arterial lines and nitroprusside?
Yeah, so like I said, I don't have a ton of experience with nitroprusside. However, I've heard, and I believe it was Dr. Scott Weingart from MCRIT. He did a podcast, and he was saying that nitroprusside is like a Formula One race car, where like you just give a little bit and it can drastically affect your vitals.
Yeah.
So I would tend to agree with that. If you're taking non-invasives and you're titrating nitroprusside, I would be of the mind that I would like to have an art line. I think an art line in these situations, regardless, is phenomenal. But
Like you don't want to delay you don't want to delay time just because you want an arterial line. But if that facility is sitting there waiting for you to get there to transport, and if they're like, I got 10 minutes, like maybe I can throw in an art line for them quick, that's huge.
yeah, yeah. And now, if with nitroprusside, that probably is a good option. I think one of them. So nitroprusside actually has nitric oxide in it, right? So it's actually going in and the nitric oxide is causing the dilation. When you give something like nitroglycerin, it goes in and it makes the endothelium release nitric oxide. So it goes in and through a signaling pathway and actually it doesn't actually put nitric oxide in. It's going in and telling the endothelium, hey, release nitro or nitric oxide here, which is why you think about somebody who's got like a plaque or a clot or something like that. The nitro isn't going to go in and dilate that area because the nitric oxide can't get out of the endothelium there. And that's why nitroprusside works so well, is because it's actually going in there. It's not like nitro where you're counting on a system kicking in and then releasing it, almost like you see with glucagon.
Yeah, it just already does
body to release. Yeah. But I agree. Like I would be very careful with that. I may also be more prone to do something like nitro. I'm not a big fan of just doing labetalol boluses. I like drips for this situation.
I really like our
Because-
esmolol guideline.
Yeah, because you can titrate it. So I think in the situation where you're like,
Yeah.
man, I can't get control of this blood pressure, my order without an art line in would probably be, like we said, pain, esmolol, nicardipine, and then probably starting a nitroglycerin infusion. And then if you have an art line or whatever, then maybe considering nitroprusside. And that
Yeah.
may just be us being a little too cautious. You might have a subset of people that are like, oh no, we run nitroprusside all the time without an art line. But without the experience that in seeing how those titrations and watching
Yeah.
them in an ICU, I'm just a little hesitant with it.
And especially in a very dynamic environment as we work, we don't always have the luxury of being in a room where we can walk across the room and grab something. We're in a smaller, basically like a tin can in the air, and things can go wrong very quickly, very fast, and we have to be ready to manage that. And I feel like if you have the experience, it's great. Like still, like you have to kind of plan for worst case scenario in the aircraft. And I think in our situation, you're like, so like in the event this does happen, they do pop, I'm going to do this and you're going to do that. We had that plan already in sight.
Yeah, right down to having the blood not spiked, but just, all right, it's right here. This is where the tubing is,
Yep.
warmer, how we would set that up. I think this is one patient too that it makes sense to probably, if you don't have an art line, get an actual systolic, like an actual manual blood pressure on, knowing that our automated blood pressure cuffs or any basically oscillometric blood pressure cuff.
Yeah, they give you
Measures
a
the
map,
map.
and they calculate your other numbers. Yeah.
Yeah. Which generally that's what you care about the most, is right? That's what's perfusing the organs.
Right.
But in this one, you do care about that shearing force. I did a podcast with Brian Bowling, who's a nurse practitioner, and we were talking about that. And he's, this is one population where it makes sense to know what is that systolic, what is
Right.
that shearing force that's coming through, instead of just trying to guess based off of an algorithm. Not that you could do it in flight by doing palpation, but again, an art line would be phenomenal, or if not, just getting at least one to start off with at the actual
Yeah.
hospital. I noticed some of the recommendations also talked about TXA. It's finding the right time for it. Obviously, an aneurysm doesn't really make sense to give TXA, but once they start dissecting, I think that does make sense. And I don't know if it's been studied well enough, but I did see it in quite a few recommendations.
Yeah, I feel like it's very case by case. One depends on where you're at in the process of if they have dissected, if they're about to, or if they're probably not going to, they're just going to the ICU to be managed.
Mm-hmm.
Yeah, I feel like there's a popular opinion where some people are like, you don't need to give it unless they're rupturing. And then there's the people that if I give it now and they do rupture, then I'm already ahead of the game. And I feel like I hear both sides. I agree like on both things, but I feel like it really comes down to whatever your preference is.
Thank you so much for coming on, man. I appreciate it. Great discussion. And if we come up with anything or we see any evidence, we'll keep this conversation going and maybe do a follow-up episode.
Yeah, for sure. I got access to up to date now with the guideline stuff. So I'll be keeping my eye out for articles and anything that I can find to help. And if you ever have any other things you want to discuss, let me know. So thanks for having me.